Hello and welcome to the Virginia Tech Carilion School of Medicine Hand and Upper Extremity Surgery Case of the Month. My name is Amr DeBase. I'm the current hand surgery fellow. The attending for September 2024 is Dr. Cesar Bravo. The case of the month is complex revision total elbow arthroplasty with allograft prosthetic composite. I have no disclosures. So the patient is AM. She's a 61-year-old right-hand dominant female with past medical history of rheumatoid arthritis. She underwent a total elbow arthroplasty in 2011 with another surgeon for her rheumatoid elbow. This lasted her around 11 years without any symptoms until she had significant pain and instability. She was seen by Dr. Bravo in January 2023 for the first time. For her past medical history, she has chronic anemia, eczema, OSA, and rheumatoid. She's single, disabled secondary to her rheumatoid arthritis. She's a former smoker and drinks occasionally. For her medications, she's on some anti-inflammatory medications as well as her rheumatoid arthritis medications. For physical exam, she has a 10-degree extension lag, flexion to 140 degrees, full pronation, full supination. She's a well-healed posterior lateral incision. She has 0 out of 5 strength to her triceps and increased fluid over the olecranon bursa. She had good intrinsic hand function, full composite grip, and subtle weakness of the first dorsal interosseous. Here are x-rays from that visit with Dr. Bravo, 4 views of the elbow demonstrating significant osteolysis around the ulnar component with evidence of loosening concerning for either aseptic loosening or infection. Here you can see arrows noting the increased fluid over the olecranon bursa correlating with her triceps insufficiency. So for assessment, the patient has a right total elbow arthroplasty, osteolysis with loosening of the ulnar component and triceps failure. So the plan is labs to evaluate for infection and a CT scan to evaluate the degree of osteolysis and loosening of the ulnar component. Here you can see CT scan slices, first looking at the axial slices, demonstrating significant osteolysis and loosening of the ulnar component of the total elbow. And then looking at the sagittal slices, again redemonstrating this significant osteolysis and loosening. For the patient's labs, her ESR was elevated at 37, her CRP was elevated at 1.32. After her aspiration, the lab showed negative for any organisms. Her symptoms, however, still cause her significant difficulty with ADLs and with getting to sleep at night. On August 21st, the first of a 2-stage revision was performed. We explanted the ulnar component only as the humerus was well fixed and we weren't concerned for infection at the time. We used an articulating spacer, and this was done with a long ulnar stem which was coated with antibiotic bone cement, and the antibiotic mix was gentamicin and vancomycin. At this time, the intra-op cultures were negative. Stimulant beads, which are calcium sulfate beads mixed with vancomycin and tobramycin, were also utilized, as well as 2 grams of vancomycin powder in the soft tissues. So just some interim history. The plan was to proceed with the second stage of her procedure in 6 weeks. After the first stage, however, the patient had new onset of significant drainage and a large seroma while on rifampin and Bactrim. The seroma was aspirated and sent for culture, which unfortunately yielded Enterococcus faecalis, and the plan at that point was to abort reimplantation and repeat the irrigation and debridement. Here are x-rays from October 18th. This is after explantation of both components on October 2nd. You can see the significant bone loss after all the debridement here, and the cortical defect developed in the dorsal aspect of the ulnar shaft. The ulnar or the intraoperative cultures at that time were also negative. The patient was doing well after the surgery. She had no pain but moderate swelling. However, her labs continued to be elevated with an ESR of 102 and a CRP of 2.8. The plan at that time was to again abort any sort of plan to reimplant and repeat irrigation and debridement. Here, x-rays from November 15th after another irrigation debridement, and you can see here the significant bone loss and osteolysis after all of the irrigation and debridements. So after 2 more debridements, long-term IV antibiotics, and transition to oral antibiotics under the guidance of infectious disease, the patient continued to improve for 9 months with an antibiotic holiday. Her ESR was 66 and CRP was 1.3, elevated mildly. We repeated an aspiration that ended up being negative. Due to the improved clinical picture with mildly elevated inflammatory markers, which were seen to be because of the patient's RA on a DMARD holiday, the decision was made to move forward with reimplantation. Here are x-rays of the forearm that we used to establish length for surgical planning of the reconstruction. You can see here on this AP of the forearm on the right, between the tip of the olecranon and the proximal aspect of this cortical defect is around 8 centimeters, and the distal aspect is around 11 centimeters. And so we use this to plan for the reconstruction. So the question becomes is how to reconstruct this large defect. Well, we looked to a paper in 2013 out of JBJS from the Mayo Clinic by Mori et al. Looking at allograft prosthetic composite reconstruction for massive bone loss, including catastrophic failure and total elbows. And we specifically looked at the ulnar-sided failure. In this paper, they came up with 3 different treatment strategies for the ulnar component, type 1, type 2, and type 3. We elected to utilize a type 2 approach, and rather than using cerclage fixation, we planned on using plate fixation. We took the patient back to the operating room, and a posterior approach was performed. We excised all 9 viable skin tissue. Deep cultures were obtained from synovial fluid, and reactive tissue and ectopic bone were removed. We identified the ulnar and radial nerves proximally and protected them throughout the case. We released the extensor supinator mass off of the humerus and ulna. A capsulectomy was done and deep tissues were obtained. Fresh frozen specimens were obtained and were negative. After a thorough debridement, we proceeded to the humeral side of the elbow. This was reamed up to 8 millimeters for a 150 millimeter long stem. And we measured the amount needed to resect the proximal ulna here. You can see on this right clinical photo with the ruler. This correlated with the pre-op template, 11 centimeters from the tip of the olecranon to the distal aspect of this cortical defect, and 8 centimeters to the proximal aspect of the cortical defect. Here you can see the allograft ulna on the back table with triceps tendon intact. With the trial spool, we performed a cut for an 8 centimeter defect from the tip of the olecranon to the native cortical defect. We prepared this allograft on the back table using the total elbow bell saw reamer. And here's just another look. After we used the bell saw reamer, we accessed the intramedullary canal and broached sequentially. We then used the burr to fine-tune the bony work, and we placed the trial ulnar component. We then brought this to the field with the triceps attached and fine-tuned the cuts further. Here you can see what the final allograft looked like with the trial ulnar stem in place. We performed a step cut, which fit nicely with the native ulna. We plated the allograft ulna to the native ulna with a 10-hole 3.5 millimeter Synthes LCP plate. We first put the plate fixation with the trial stem in place under fluoroscopic guidance. Final implants were then placed with antibiotic-loaded cement both on the humeral and ulnar side. The triceps was then reconstructed by passing donor tendon through native tendon in a pulver taft weave in side-to-side fashion with PDS sutures. So here you can see the clinical photos on the left, plating the ulna with the trial components, and then the final humeral component. And here you can see the trial humeral component, trial ulnar component, and beginning to put the plate on. So here are the final clinical photos. We used a Wright Medical Latitude EV total elbow system. The ulnar stem measured 125 millimeters in length, the humerus 150 millimeters in length, with a small humeral spool. 2 cement restrictors were placed. A right ulnar cap was placed. The cement was mixed with vancomycin powder, and we also used vanco powder in the soft tissues. The plate that we used with the Synthes 3.5 millimeter LCP stainless steel 10-hole plate. Here you can see in the clinical photos we used some leftover allograft ulna to bone graft this posterior defect in the humerus, and we also used some of that bone to wedge in a wedge of bone into the anterior flange of the final humeral component. So here's the final humeral component being cemented in and wedging in that bone graft, and on the right you can see the final construct after plating the native ulna to the allograft ulna, and then the final humeral component, and this is prior to the triceps reconstruction. So here are the immediate post-op x-rays of a type 2 APC reconstruction done with triceps reconstruction. You can see everything appears to be in appropriate position, and we were very, very happy with the immediate post-op x-rays. For a post-op protocol, our plan was to place the patient in posterior long arm splint for 10 to 14 days at 45 degrees of flexion. We progressed her 15 degrees every 2 weeks up to 90 degrees to protect the triceps reconstruction. Prophylactically, she was on amoxicillin 500 milligrams PO/TID for 4 weeks per infectious disease. Her DMARD for her RA was to start once her wound was completely healed, approximately 3 weeks postoperatively. Here are her most recent x-rays around 1 month post-op. You can see everything appears to be still in appropriate position with no obvious catastrophic failure. Her elbow active range of motion at this time is a painless 5 to 75 degrees in a hinged elbow brace, and this is limited by our postoperative protocol at this time, and the patient is continuing to progress nicely. Thank you very much for watching, and we'll see you guys in the next one.